What other factors do you consider when determining a treatment approach?
The human experience that comes to the bedside as we consider, treatments, it's so multifactorial and multi-complex that all of that needs to be brought into consideration. So whenever I walk into the room, I tell residents, usually kind of the medical part can be resolved pretty quick. But we're reading, how much can we communicate? What's the level of understanding? What do I understand about the support system for this person? Is this someone who can drive to the treatment center? Is this someone perhaps whose other medical conditions would create certain challenges in how they're going to be treated? This person is telling me they do daily, hikes for 4 miles. Well, that's different from someone who I see comes into the clinic and has to use a cane. So we try to integrate all of that information to make the right decisions. I've made a lot of my career in the early years, working and showing how, for instance, genetic factors are important. And I've come to realize later in my career and through, some of the very elegant work that other colleagues have done, that these factors are just as important in determining the ultimate outcome of patients. So, whenever I talk about that clinical experience, there's two things I always tell the residents, and I use the residents a lot because I think it's a good example of how we aspire to interact with patients. Number one is every single encounter is a final exam. You have to put your best foot forward. Every single exam is, every single encounter should be considered a final exam. Number two is when I walk into that room, there are 3 things I do, and particularly the first time I meet a person. So number one is connect, right? We cannot have a conversation, and I'm not going to be able to move forward unless we have a human connection, and I have gained the trust of the patient and the family members that are there. So that's number one. The second point is decide, and that is usually, okay, we're going to do this treatment or that. And that is a small part. Most of the time for me, that's a very small fraction of the time and of the mental energy that I consume. There's cases that are more complicated, but most of the time it's pretty straightforward. So it's connect, decide, do very small, and then on the other end is explain. So that's how, I can connect. I propose we do this, and then why are we going to do it, and what can you expect? And if you can do those 3 things, I think that goes a long way in establishing a fruitful and a productive relationship with the patient and their families.
Mm-hmm. I would suspect that you also take into consideration the patient's health, their age, maybe test results, side effects, things like that.
Of course. So we look at the medical record, and with the advent of course, the electronic record and all the testing we do, our consideration is quite complex because we have to look at all those factors and, the age and comorbidities. And it's rare that we would take one factor alone that would trump everything else. We usually have to integrate the information. And the same is true when we manage myeloma patients and we're monitoring, their protein levels and their response to treatment. I tell patients, they ask me, okay, what would you do? What's the magic number for this or that? I say, it's a little bit like you're flying a Cessna, plane, and you have all these dials in your dashboard, and that's how we manage the situation. Is the integration of all of that information.
Right. Can you help us understand, Dr. Fonseca, how test results may affect treatment options?
Sure, happy to do that. So, in myeloma, we're very fortunate in that we have, and it's not the topic for today, but we have the best biomarker that exists for any cancer. And that is that we can measure the proteins that are associated with the growth of the cells. And we have multiple tests that we can do, and we do them in the blood and we do them in the urine. And there's simple tests that have been done for decades now that allows to monitor how a person is doing with regards to their disease. And I use the following analogy. Myeloma cells live inside the bones, as I mentioned, in the bone marrow, and they don't come out into the blood, so we cannot measure them. So indirectly, we can measure how many they are and how they are behaving by measuring this protein. So I use the analogy of, imagine you're walking in a street and you see smoke coming out of a building. So there are 2 things you can do. First is you diagnose that there is a fire inside the building, right? And we see that with myeloma by measuring these abnormal proteins. But then as a fire, fighting team comes on, you can gauge whether they're making progress or not, but the amount of smoke that comes out. And that's exactly what we do when we monitor myeloma. We monitor the M spike, the serum free light chain, the urinary proteins, and that's how we make those determinations. Now, at the same time we do that, we have to look indirectly at the rest of the body. So we have to look at the kidney function, we have to look at the blood counts, we have to look at the hemoglobin and the red cell count, because that can A, start on the wrong foot because of the myeloma itself, but B, can also suffer as a consequence of our treatments. So it is, again, that idea of having the multiple dials in a dashboard that allows to reach our practice, and we have to be adjusting. So, if we measure the proteins and we're doing great, but then at the same time we see we're suffering in blood counts, then we may need to adjust doses or provide supportive treatment. If we don't see the proteins go down, then that may mean we need to change to a different form of treatment, or that the person is unfortunately, refractory or relapsing to something. So that's how we integrate the test results into our management.